Okay, now when we're talking about the cervical spine, we are talking about the upper cervical spine, the mid cervical spine, the lower cervical spine. And we're talking about the upper cervical will be the AAAO articulation, then the mid cervical will be C2 through about maybe C5 or 6, and then the lower cervical will be C6 through maybe around T1. And all these parts of the cervical spine have different characteristics that may be important in terms of how we diagnose these problems and how we treat them. So we'll look at the upper cervical first, and you have the upper cervical is made up of the atlas and the axis, and the atlas is really just a circular bone with these large articular pillars here to accept the condyles of the occiput. It's just a round bone with an anterior arch and a posterior arch, and oops, cut it backwards. The anterior arch and the posterior arch. Okay, so and there's no disc here. There's no disc in between the occipital-atlantal articulation. There's no disc between the atlas and the axis. What we have is the odontoid, and we have this odontoid process coming in up into the arch of the atlas, and it forms a joint here. You actually have, in the AO articulation, you have, or AA articulation, you have four joints. You have your facet joints, sorry. You have your facet joints right here, and you also have a joint here in the on the dens and here on the dens, so that you have the facets plus you have a joint here and a joint here, where the atlas rotates around the dens. You have a this would be your arch of your atlas here, and this is the dens coming up, and then you have articular cartilage here, and then you have this transverse ligament holding the dens against the atlas, and you have a joint here between this transverse ligament and the dens. Okay, this can be a real bad problem with your rheumatoid patients, and so you always want to be concerned about any kind of weird symptoms these people complain of in terms of like bending forward and stuff. They get dizzy. If that happens, they need to be seen by a neurosurgeon to look at this area right here. This area many times has to be fixed in rheumatoid patients, and that's why we don't do too much with rheumatoids. Treat them symptomatically for pain, but as far as mechanical correction, you've got destruction of tissues a lot of times. A lot of times you get, with the rheumatoid, this joint here just gets destroyed, and the dens starts to infringe on the spinal cord, or actually up into the foramen magnum. At any rate, you have this joint right here, and you have the facet joint of the atlas and the axis. These vertebrae are very atypical. Like I said, there is no disc here, and the nerve structure here. There's no intervertebral foramen for C1 or C2 nerve roots to come out of. What they do is they just come out over top of the lamina. And sorry, skipping around here so much. They just come out over top of the lamina and anastomose, and when we talk about the suboccipital triangle and so forth, we will be talking about the anastomosis of C1 and C2, and the suboccipital muscles and how they function in these postural dysfunction syndromes, and how you treat them. Okay, so that's AA and AO. The mid-cervical spine is like C3 through 6 here, and what the unusual parts of this, now C2 has a big spinous process that you can palpate here, and then C7 and T1 have big spinous processes that you can very easily palpate. You can palpate all these joints. They're in the valley between this and the transverse process, and you can actually palpate all these joints. When they get sore, you can identify which ones they are, and so forth. The unusual aspects of these bones are the transverse processes are not really like transverse processes we see in the lumbar spine and thoracic spine. These are what they call these gutters, and they are gutters, and the nerve roots come out, they're attached to this gutter, and they come out through this gutter and then come on out into the periphery. They also have transverse foramen in them, like going right up through here like so. So it's got a lot of stuff in it. This transverse foramen is for what? It's for the vertebral artery. And the vertebral artery just traverses up through these transverse foramen, comes up and goes all the way up into C1, and then curves out and over and up over the lamina, up into the foramen magnum, and then eventually gets up into the circle of Willis to help supply the posterior brain with blood. So you have a structure here that's directly relevant to the brain blood supply, especially the posterior brain. And vertebral artery disease is not an uncommon thing. And with vertebral artery disease, we're talking about posterior brain symptoms. And when you get that kind of stuff, it's out of our realm. It's another red flag. Okay? So at any rate, you got the vertebral artery, and let's see what else we're going to look at. These facet joints, you want to look at the attitude of them. You can see they're all diagonally arranged sort of similarly, and they are joints. They have hyaline cartilage, they have capsules and ligaments supporting them, and they are arthrodial joints. Again, arthrodial being gliding only. They can only glide up or down. And then we're going to talk about this up and down gliding movement here, and what effect it has on the intervertebral foramen and other things. Okay. Now you might want to, you also want to note, like on this particular slide, are the joints of von Lischka, and these are what they call the posterior inner body joints right here. And there's also hyaline cartilage there, but there's no capsule, so they're not really true joints, but they have the capacity to spur and give you several kinds of problems. They are supportive in nature, of course, and they also protect, in a way, the nerve root from the disc in these patients. We didn't say much about the disc, but starting with C2, 3, 4, you have discs at all these levels between the vertebral bodies. Okay. Now, this slide shows a lot of structural things that you have to be acutely aware of in when you're visualizing the problems of the patient, because this is the intervertebral foramen here, and the structures that are in there. It's just like the suprahumeral joint. You got 6 or 7 things here that can cause problems, and they do cause problems. Here's your joint of von Lischka, right here that borders the intervertebral foramen right here and helps to protect this area from disc protrusions, although that can be violated. It is violated many times. And of course, here's your spinal cord coming out, and your dura mater that will end up as perineurium down in here. And once the nerve root has come through, you have your sympathetic system here getting started, and then you have your anterior and posterior primary divisions of the nerve root. You got your vertebral artery right here. So you have a joint right here that's capable of spurring. You have a joint right here that's capable of spurring. All the tissue in here takes up the whole mediolateral diameter of the intervertebral canal. You don't have any room in here for anything else, okay, going mediolaterally. And so if you have a disc protrusion, if you have a little spur, if you have coming off of the joint of Lateral or you have a little spur or swelling of this facet joint, there is no room for it here to swell into the intervertebral foramen. Therefore, if it doesn't have anywhere to go and it pushes on it, you've got a pressure problem right here. And of course, this is how you get cervical radiculopathies. And the causes of them can be anything in anything in all these tissues. The main thing causing them, of course, is the disc and protrusions of the disc and spurring and hypertrophy of the joint of meniscus and or the facet joints. So we want to be real cognizant of that. And then as we look at it from an oblique view, and that's another thing you want to be concerned about with X-rays, you always, whenever X-rays are done, you always like to see three views. The AP, which gives you a real nice view of the bones of the bodies, and the lateral does the same thing, but you need an oblique view to view the intervertebral foramen here. And that's almost all cervical films will do that. Sometimes they don't, though, if they're not ordered. When you have an oblique view, then you get to look in this hole right here, and you get to see the nerve root in the hole through which it traverses, and you can see many times compromise in these areas from the joints of meniscus or the facet joints or what are the discs that's coming out here. Okay, so beyond that, what did I do? Somehow got, okay, here we go. All right. Now this drawing comes out of one of Paris's books, and it shows an arthrosis here of a facet joint. And that, when we get into diagnostics, that can be a problem. You can obviously get osteoarthritis in any joint of the body, and when it occurs in the neck, you get these kinds of things. The capsule's getting thickened and arthritic and causing a problem, as you can see on this slide, with a compression of this nerve root right here. Now, the next thing we want to look at here is the effect of movement on the intervertebral foramen. And what I like to do here is I like to liken this to the wings of an airplane and how they're slanted like this to make the plane go up or down. And if you think of yourself as having a facet joint here and a facet joint here, and all they can do is go up or down. If they both go up, then you have flexion. If they both go down, you have extension. If one goes up and one goes down, you have rotation to the opposite side. And then if you have side bending, the same thing happens. You have one going up and one going down. Now the effect of that movement on intervertebral foramen is critical, because as the facet joint glides down upward here, and this one conversely will be going in this direction, this opens the intervertebral foramen, because the facet joint is right here, and the pedicle of this particular vertebra in the lamina form this intervertebral foramen. So when you do flexion, you open this hole. When you do extension, you close the hole. When you do side bending to the same side, going down, you close the hole. And when you do side bending or rotation the opposite side, you open the hole. So that if you have a foraminal encroachment problem, you want to be acutely aware of what you're doing with exercise to have what effect exercise is going to have on that intervertebral foramen. You may actually have peripheralization of pain with, let's say, rotation or extension to the same side. Now, again, peripheralization of pain phenomena works throughout the body, and you always let that be your guiding indicator about what you're doing to hurt or help the patient. So, we have these structures, and we want to talk now about some of the causes of pain and dysfunction in the cervical spine. And again, just to remind you what I started out with, is that postural dysfunction is the most common thing you see in there, and we're not going to talk about that extensively, except to say you know what good posture is, and the good posture of the head and neck have to start and end with the treatment of all these problems. Okay, this particular study shows an entity that is somewhat, or more than somewhat, significantly controversial, but has been proven by a few studies, and that they're called meniscoid inclusions. All joints that have a capsule have these synovial fringes that line the joint all the way around, and the synovial fringes go inside the joint to a degree. They're not supposed to go too far in. And that's all right.